Let's talk about some diagnostic interpretation. There are 6 basic patterns of lung disease when visualized by chest X-rays: airspace or alveolar opacities, interstitial opacities, nodules and masses, lymphadenopathy, which is another name for large lymph nodes, cysts and cavities, and then pleural abnormalities. I'll try to show you examples of all of them. Alveolar opacities can also be thought of like cloud-like opacities, versus interstitial, which are more linear or also called reticular opacities. A nodule and mass are both rounded but differ in terms of their size. When we talk about airspace or alveolar opacities, we're talking about replacement of the air inside the alveoli by an alternative substance, such as cells, pus, blood, water, or tumors. So all of these things could potentially be inside the alveolus instead of air. Because air makes the alveolus appear black, when any of these other things have replaced air, the alveolus no longer appears black and instead appears white. So when we see whitish opacities or whitish things inside the alveolar in an alveolar pattern, we call it an alveolar opacity. Remember that the chest X-ray does not give you an answer as to which one of these is filling up the alveolus. All it tells you is that one of these might be filling up the alveolus instead of air. Some more clarification on terminology. Atelectasis means collapse of the alveoli or the parenchyma, which means there's nothing inside the alveolus. So it will not appear black, and it appears white because there's nothing inside it and multiple different alveoli have collapsed next to each other. Alveolar opacities or consolidation, like we just talked, is filling of alveoli with substance other than air, which gives it the whitish appearance. An air bronchogram means that alveoli are airless or are atelectatic, but the surrounding bronchus still has air. So it looks like a tube that is going towards an alveolus, but there's nothing inside the alveolus. So that creates an interface, as I'll show you in some of the pictures. In this X-ray, we can see both consolidation and air bronchograms. The lighter green areas are air bronchograms, where you can see a tubular type structure which is filled with air, and air being black gives this structure a black appearance, but it leads to nowhere. This is an air bronchogram. At the bases of both the right and the left lung, you can see that there's white, cloudy appearing areas. These are consolidation or alveolar infiltrates or alveolar opacities. Remember that the possibilities are cells, pus, tumor, blood, or water. The X-ray itself does not tell us which one of these issues is going on. The same air bronchograms and consolidation are visible on a CT scan as well, here depicted by white arrows. Those white arrows depict this air bronchograms, and they're surrounded by areas of atelectasis versus consolidation. That's the whitish area. The lungs should appear black on a CT scan as well, just like they do on an X-ray because of the presence of air. Interstitial opacities are linear when they're fine lines, or reticular when there are thick lines. Either way, they're linear or straight lines. They also can happen with peribronchovascular thickening and sometimes a miliary pattern. Let's look at some pictures. This is an X-ray demonstrating a straight linear opacity depicted by the orange arrows. You can also see the white arrows, which show some reticular opacities, and then the yellow triangle, which shows peribronchovascular thickening or peribronchial thickening, where the bronchus is thickened or the wall of the bronchus is thickened and there's air inside the bronchus. When we look at the CT scan, we see very similar linear or straight line appearing infiltrates. Those would be considered as reticular infiltrates. Nodules and masses, like I said before, are distinguished based on their size. A nodule is less than 3 centimeters rounded opacity versus a mass is more than 3 centimeters in size. Nodules are further described according to their number, size, borders, location, internal calcification, or cavitation. In this X-ray, you can see the white arrows depict rounded, small opacities. Those are called nodules because their size is much smaller. If you look at this X-ray, you can see a large opacity. This has become a mass. It's rounded, it's large in size or larger than 3 centimeters in size. Of course, both nodules and masses are concerning for malignancy or cancer of the lungs. In terms of a CT scan, the nodules are much more easily visible. The upper left picture depicts the lung nodules, versus masses are even easier to see than they are on an X-ray. Lymph node or lymphadenopathy. There are some characteristic locations of these lymph nodes which you should be aware of. You do not have to memorize this slide or the numbers on this slide, but be aware that there are characteristic areas or regions where you would expect to see enlarged lymph nodes. When we are looking at X-rays, we go through an interpretive strategy that looks at those areas to make sure there are no enlarged lymph nodes. The most common ones of these are the hilar regions, left and right hilar, and the aortopulmonary nodes, which would appear on those areas on the X-ray. This is an X-ray showing a mediastinal lymphadenopathy depicted by the green arrows. You can see clearly that it's enlarged or larger than it was on the previous X-ray. On a CT scan, lymph nodes are much more easier to see. If you look at the top left picture, number 10 depicts an enlarged lymph node, multiple areas of enlarged lymph nodes. This station 7 is also an area called the subcarinal lymph node area. Cysts and cavities. These are areas of lung tissue filled with air, fluid, or both. Cysts are thin-walled and usually happen in cystic lung disease. Cavities are thick-walled, and they're created when tissue necrosis happens within a lung nodule or a mass becomes air-filled. This X-ray depicts cavitary lesions with the small yellow arrows arising from necrotic lung nodules in a patient with HIV infection. On a CT scan, both cysts and cavities are easier to see and much more clear. The cysts have thin walled, as you can see here, versus cavities which are thicker walled and happen in areas of tissue necrosis. Pleural abnormalities are of 4 different types: pleural effusions, thickening, nodules, and calcifications. And I'll try to show you some images of all of these. This is a pleural effusion. We know this is an effusion because it forms a meniscus or a meniscoid type of opacity, blunting the cardiophrenic angle. The area appears white. It is hard to say if there is an infection, consolidation, or atelectasis along with the effusion in this area. That would be something that we would evaluate with an ultrasound. The reason we can call this an effusion is because of the meniscoid opacity or appearance of the opacity. On a CT scan, the area of the effusion is clearly seen as gray or darker in color compared to the black color of the air inside the lung. Pleural thickening occurs as a non-layered appearance. There is no meniscus and it defies gravity. It happens in areas which are not dependent. Appearance on a CT scan of pleural thickening, very different from that seen on an X-ray. Again, 2D versus 3D appearance. Another area of pleural thickening. Pleural nodules are easier seen on a CT scan. The arrows in black depict or show the nodules very clearly. These would be rounded opacities that lie along the pleura instead of inside the lungs. And then calcifications can happen at any in any place. I use this X-ray as a trick X-ray because it looks like there's areas of whitish opacities inside the lungs. However, remember that the pleura covers the lungs both the anteriorly and posteriorly along with the sides. So on a 2D picture, you would not be able to say if the opacities are inside the lung or outside the lung. These are pleural calcifications and not opacities inside the lung. On a CT scan, you would see areas of very bright shadows, almost similar to bone, along the pleura or on the edges, around the edges of the lung. Again, back to our case, one of the differential diagnoses in this lady could be PE. A CT angiogram is the diagnostic test of choice now for PE. And what you would see is this bright area in the center where the red arrow is. Right above the red arrow is the pulmonary artery. And you can see a clot that lies inside the pulmonary artery shown by the red arrow. This is called a saddle embolus because it's saddling the PA or pulmonary artery branches left and right. The yellow arrowheads show the actual clot burden. This is a high-resolution CT scan in a patient with chronic hypersensitivity pneumonitis. It is a form of interstitial lung disease. If you look at the blue arrowheads, those are thickened interlobular septa. Those are the primary or structural units of the lungs. The yellow arrowheads show the prominent fissure due to fibrosis. The red arrows show the bronchi are going all the way out to the periphery. Normally this should not happen, and when this happens, it means that there's some fibrosis or scarring that's happening, leading to traction bronchiectasis. And if you look at the orange arrow, it shows some mosaic attenuation, which means that there are areas in the lung that are more black compared to areas that are less black, or conversely, you can say areas of the lung that are more white compared to the other areas. This is a high-resolution CT scan on a patient with sarcoidosis. If you look at the nodular opacities that you can see along the fissure depicted with the orange arrows, those are characteristic of granulomatous inflammation. You can also see rounded areas of ground glass opacities depicted by the blue arrowheads. These are characteristic, again, for patients with sarcoidosis. Finally, lung or chest MRI is also possible, but there are some advantages and disadvantages of this. It is a non-invasive study with no ionizing radiation by using static magnetic field and uses intrinsic contrast, so no external contrast needs to be given. However, the disadvantages are that it requires a long time for completion and greater cooperation of the patient, which is not always possible. It's not suitable for obese patients or claustrophobic patients, and patients with metallic objects or implants are not able to get an MRI. Cardiac MRI is much more commonly performed and is much more standardized in terms of getting information about right-sided heart disease and diseases like sarcoidosis and amyloidosis. These are some other indications for cardiac MRI